Some problems only become apparent long after discharge from critical care. For example, I saw a patient recently who had experienced pain, numbness and loss of function in her hand. On further investigation, this turned out to be due to an ulnar nerve palsy. This may have been sustained during a long transfer from one intensive care unit to another, or possibly during the critical care stay itself, when patients lose muscle mass and pressure on the ulnar nerve is sustained. This reminds us that what we do acutely can have a profound impact on the patient's long-term recovery. My experience of following up patients and their families after critical illness is that often patients and their families just want to talk to somebody who has an idea of what they've been through, about their experiences during critical care and during recovery. The critical care multidisciplinary team support this process. Due to the sometimes complex nature of critical illness and rehabilitation, some patients and their families don't get access to the follow-up that they need. Greater collaboration between critical care and primary care services can only improve the experience for patients and their families.
Cognitive dysfunction is not always obvious to spot. It can present quite late in patients' recovery. Patients often initially concentrate on their physical recovery and return of that side of their health, but cognitive problems can be unmasked. We had a patient in clinic who was a high-functioning accountant and appeared physically to be very well. It was only on further questioning of her husband that he mentioned that things weren't quite right. A further screening questionnaire was able to elicit that there were attention and memory problems, and we were able to make an onward referral for help for these. Patients with generic cognitive problems will benefit from further referral if they are picked up in a multidisciplinary assessment or care plan session. Being a junior doctor and visiting intensive care is a scary enough experience, but to have a loved one critically unwell on an intensive care unit can be very traumatic. So it's quite remarkable that the majority of relatives do escape relatively unscathed through an experience like this. An example of this was the wife of a patient who was so traumatised by visiting her husband in his critical illness that she was entirely unable to set foot in our hospital. So it's really important that we acknowledge and understand that the family are crucial in the recovery of the patient, and that members of the family may also suffer from PTSD. We should be looking out for them as well.